Welcome, everybody, to today's Focus Friday. This is the Good Friday edition of our Focus Friday. Although, Senator Tarte, I don't think we ever have a bad Focus Friday, do we?
I don't think so.
But welcome, everybody. The program is sponsored, presented by Novant Health. And we have Mike Riley on the line today. Mike, you want to give us a healthcare update? I'm seeing that we have COVID is starting to make a little bit of different variant run. Can you share a little bit about that, but also share with us what's going on at Novant?
Yeah, I'd love to, Bill. Thank you. And thank you, Senator, for being here today. We're honored to have you. I'm very excited about hearing what you have to say. And I'm a little worried also about what Jeff's going to ask you. So you never know. As far as the hospital, 2 months ago, we had anywhere from 30 to 50 COVID patients in our 140 bed hospital. Over the last month, it's been 3 to 5. So we really have those numbers have really gone down dramatically. I'm still struggling in a big way, and this is Novant. This is I think healthcare contract labor for contract nurses. The cost of them has really skyrocketed. We're paying quadruple what we pay for a typical nurse, and it's interesting. It used to be when with contract nurses, they would have to travel, to a desolate location to get a travel assignment, and now they just have to go to Hickory or Greensboro, and they're getting paid triple, and we're paying quadruple. So that's been hurting us financially. We're continuing to see lots of patients. Otherwise we're doing well, but that's really hit us. The other thing, we've got the senator on, so I've got to talk a little bit about certificate of need and how important that is to us. It seems like an arduous regulatory process, and it seems like it's a pain, and it takes forever to get healthcare assets approved. But it does give the hospitals, and especially existing hospitals, a little bit of a leg up. And that's as long as by mission and by regulatory and legal requirements, we have to take all comers regardless of their ability to pay. That little boost that we get with CON is really helpful. Otherwise, I think we'd have venture capitalists and others come into the system and take all the cream from the top of the hospitals, all the well-paying patients and well-paying procedures, and set up freestanding surgery centers and imaging centers and those kind of things. And then the other thing, Medicaid and Medicaid expansion, we would love to see that I talked about travel nurses earlier, with our costs rising through inflation, through everything that everybody else is seeing. We really can't raise prices. We can, but we can't get reimbursed anymore. And Medicaid expansion, it's the right thing to do for a big swath of the population who can't get insured, but it also would help with a lot of these issues that hospitals are seeing. That's all I'm going to say for today. One last thing I want to say, we're seeing more and more just this society. People healthcare workers are being assaulted both verbally and physically, more than I've ever seen in my career. And I think anything that we can do, tell your employees, tell your friends, tell your family, be nice to the nurses when you go in. It's they're doing the best they can. And this is not just a Huntersville thing. This is a nationwide thing. We're seeing many, many more assaults, both verbally and physically, on healthcare workers. So just make you aware of that. And that's all I've got.
Mike, we want to thank Novant for being our presenting sponsor of this program. And the certificate of need process is one of the things that is on our legislative agenda that the Lake Norman Chamber of Commerce supports. We'll be sharing that with the senator and the legislature. Jeff, great program today. I'm going to turn it over to you, sir.
All right. Thank you, Bill. Mike, again, just a nod back to Novant, not just really for your sponsorship of our program. That's such a minor thing, really, in the scale of what Novant does for the residents of the Lake Norman area, and more importantly, across the entire region and your health system. You are one of the truly premier healthcare providers in the nation. Your system is well regarded. Your leadership, both locally and throughout the system, is renowned. So you are truly looked up to as one of the leaders and icons in our community. So again, appreciate you being here. And you're stealing my thunder, because those are definitely areas we're going to try to get to and touch on. I'll bounce around a little bit because that's the way my brain works. But today we have literally the honor and pleasure to have State Senator Joyce Krawiec with us today. And Senator, just as background, and then we're going to give you the floor to kind of give us an update on what's going on, has been going on from a healthcare side. But I think it's important for everybody to know you do chair the healthcare committee in the Senate, and obviously with the joint committees with the House members. But you also, in a bigger role, control the purse strings for HHS, and that you are the appropriations chair for HHS. That is a significant role, combined with the fact that you sit on the finance committee. So you are all things dollars and cents, which are important to set priorities and how we allocate our good tax dollars. But two other interesting committees I believe you serve on, and we may touch on them a little bit later on, even though today's focus is healthcare, is talking about your membership on the Pensions and Retirement Committee. And the one that's gotten all the news lately is the Redistricting and Elections Committee. And I know you were mentioned you were hosting one of the district reviews in the 6th, I believe, reviewing some of the district maps or plan maps. So we'll hopefully get a chance to jump into that. But Joyce, having served beside you and down the hall from you, it is an absolute pleasure to see you here. It's, again, a pleasure and again, a real treat for us that you're able to join us in your busy schedule. And with that, I'm going to give you the floor.
Thank you, Jeff. And I still miss you. And Jeff is a dear friend, so it's great to see him again. And thank you all for being here and for having me. I want to address one thing Mike said about the assaults on employees at the hospitals. I have heard that, Mike, from, I met with Elizabeth Alton from Novant just recently, and she had given me some examples of things that have been happening. And I did talk with my district attorney about that, to say her thoughts were that the magistrates just didn't understand a lot of it was behavioral issues, and they were just reluctant to even, they were reluctant to do anything if it was a behavioral issue. But we can't have that. So I agree with you 100%. And we all need to talk to our local DAs about that and make sure that they're aware that the magistrates are not following through on charges, because we cannot continue to let that happen. As Jeff said, I chair all things healthcare, and I don't have a healthcare background, so don't even ask how that happened. And it's a very complex system, as you all know. And Jeff didn't mention the one big committee that we're doing right now is access to healthcare and Medicaid expansion. And we've had some great meetings. We have one left. We've heard from, oh gosh, I don't know how many states we've heard from to see how they went through the process of expanding Medicaid, the do's and the don'ts. We've learned a lot from them. So we're taking some pieces from things that those states did, and we're going to try to craft something that will be specific for North Carolina. But we do have to improve access, as you all know, and certificate of need is one of the things that's on the agenda. And Mike mentioned that, but there is so much data out there, and I hope that you'll all look at it, because Mike and I are going to disagree on this. There is so much data that shows that certificate of need in North Carolina is the 4th most regulated in the entire country. So many states have done away with it completely. Others have sort of piecemealed, but North Carolina is one of the worst. And we have to do something. We've got to improve our access, and that's one of the things. And I don't know if you heard the story of the doctor here in Winston-Salem that had a lawsuit going over MRIs. And he was actually taking care of a lot in our community that were underserved and underprivileged and didn't have health care. And so he was offering, he was renting the MRIs, and he was offering MRIs at a reduced cost. He finally ended up, when COVID hit, he just retired. So I think Dr. Singleton has picked up that lawsuit from out in the East. And his problem is he is an eye surgeon, and he can do part of a procedure in his office, and then he has to take the patient down the street to the hospital to have the other part of the surgery done. Well, that's That's ridiculous. That doesn't even make any sense to normal people. And when I talk about this issue with people, they will say, how in the world did we ever get there, that you have to have permission to open up? And I think it's going to help a lot of hospitals, because now you can't even make an addition, or even from my understanding, Senator Heiss told a story about his hospital couldn't move one of the imaging machines to another part of the hospital. They were trying to change some rooms around, and they had to go through certificate of need to even move that. So there's a lot of things we have to do, and we have to have some modifications. I don't know what they're going to be, but we'll work with the hospitals are of course opposed, and we'll work with them as much as we can. But we have to have some changes in that system. Another thing we're working on that is in that realm is the SAVE Act, allowing nurses to practice at their full authority. And the stories I have heard, I met with one nurse practitioner, who told me that her physician, her supervising physician, lives in Tennessee, and he's retired, but he still is licensed in North Carolina. And he flies in every 6 months and signs her documentation. And that's the only time she sees him. She has access to him if she needs it, but she says, they just don't even talk. Well, that's not supervision. So, if we're going to have supervision, it needs to be true supervision. So, gastroenterologist, my husband had a colonoscopy, and of course they had a CRNA doing the anesthesia. And I asked him, I said, so you supervise that nurse anesthetist? And he said, heavens no, I don't know anything about anesthesiology. I haven't looked at it since I was in medical school. I don't supervise her. So that's not true supervision either. She's obviously, in this case, it was a lady. So we have to have some changes to this system to improve access. Some of our rural areas we have, I think, 30 counties that have no OBGYN. So we have a huge array of supporters on the SAVE Act. And the hospitals will still be able to do whatever they want to do. They can, have the nurse anesthetist, the anesthesiologist. They can continue with whatever they're doing now. This just opens it up more for these, particularly these rural areas who have no anesthesiologist. And some of the remote areas, they have no anesthesiologists anywhere. So, we just need to look at how we can improve that system and make it better so that we can improve access, particularly to our rural areas and some of these medical deserts that we have. Jeff mentioned appropriations. We finally got a budget. Jeff, as you know, we have not had a budget since Governor Cooper had been elected, but we did finally get one. And that was part of the agreement with him to sign the budget, was that we would set up this committee to study access to health care and Medicaid expansion, to see ways to improve the system. And so that's how this committee came about, that we're looking at all of these ways to do that. I do believe we will expand Medicaid. We do have opposition. We have some of our folks who just are never going to support it no matter what we do. So we've got a lot of work to do to gain support, but I'm excited about it. And I think that we will get it in the end. We're trying to do some things that we can get more people on board. So it will be requiring some waivers and things like that. And some states have gotten waivers for certain things. Some of our members want work requirements, or they're not going to support it. And the court has already said we can't do that. I think it's still in litigation, but so far the court has said, no, you can't make it a requirement. So we are going to try to include some workforce development in there so that we can offer it. We can have training and things for these folks, and we can offer it to them and try to encourage them to get specific training and get into the workforce. But most of those people on Medicaid already work. The ones that we will be expanding to are really the working poor. They work, they have jobs, but they can't afford insurance. And I know lots of them, and I'm sure all of you do. We see them every day. And so those are the ones that we really want to help. So I'm excited about being able to get that done. And I think we will, and I think it will be done pretty quickly. So just keep watching, and we'll see where we go there. What else did I want to tell you? We talked about the assaults. Mike mentioned this, and I hear it from everyone, the workforce shortage. In the medical field, there is a dire need for more people, for more providers in that workspace. From the long-term care facilities, the group homes, there are shortages everywhere. And one of my constituents who has he has a long-term care facility in assisted living. He told me that he was at 50% capacity because he could not get employees. So he's had to send some of his residents home. And that's tragic, because then nobody can go to work. Somebody has to be home to take care of mom. And so it's really hurting everybody across the board. And we've got to figure out a way to do something about that. And we just, we're struggling to find answers. And Mike mentioned how the rates that they're having to pay for traveling nurses. And it's not sustainable. It's just not sustainable the way that it's going now. So we have to make some improvements there, and we have to do better. So I'll be glad to take any questions from anyone if you have any, or anything specifically you want me to address.
Sure. And Joyce, what I'm going to do is start off, and we're going to need you here through lunch hour, and we'll do DoorDash for your lunch because we have a lot of things we could cover. Let's jump in with the Medicaid expansion first. I'm going to go completely against where I was going to head thought-wise, since we've talked about it. I'm curious on whether you can elaborate at all, whether you see the movement to adopt an expansion plan that's similar to what has been the traditional expansion out of the Affordable Care Act states. And I'm going to present the other side in a sense. I would say devil's advocate, but I'm opposed to Medicaid expansion. I think it's completely unnecessary if it's done in a different model. What I think the problem is, how do we ensure literally that gap population has access to affordable healthcare, right? And I know Kentucky and Arkansas, there's a blended approach, and we've had discussion years ago with Blue Cross Blue Shield as one example, where we could block grant the 90% of the funds from the federal, take the federal dollars, and actually create a special commercial plan for the gap population with the 90%, and then have a plan through an insurer like Blue Cross or Aetna or whomever, and accomplish the same thing without putting the state at financial liability for the increase, because Medicaid is one of those significant areas that messes with the budget. And as a former legislator, one of the big issues is budget predictability. And that Medicaid, because you're eligible, you're not eligible, you can become eligible again, which is appropriate, but it's so hard to predict. Has that been factored? And what is the model look like if we do some form of Medicaid expansion? I know one of the plans also was the hospitals were going to pick up the 10% differential, so the state's not obligated. But the concern is, if the feds ever move back, the states are, once somebody's enrolled, then the state's going to be obligated. Can you speak to that whole amalgamation of issues?
Yes. Well, one of that has been a concern. And as you remember, Jeff, I was very opposed to Medicaid expansion. And of course, that was when we were going to be paying 33%. The federal government has made it now where, and we really believe that at some point they're going to force it on us anyway. So we want to develop our own plan. That's part of our thought process. And we're looking at the other states that have expanded. That was a concern that the federal government would pull back on the funding because, as you know, they don't have any money except what they print and borrow. But and we can't do that here. So, you know, we have to balance our budget. But we had a concern about that, but they have not pulled back from any of the states that have done it. So we're feeling pretty secure that they're not going to renege on what they promised. So we're feeling more confident about that. The other thing is, when COVID started and we were not redetermining anybody on Medicaid, we've already expanded the rolls. We added 500,000 people since COVID started. So that was what we considered was going to be the number in that gap, was 500 to 600,000. So basically, we've already expanded it. We know of that 500,000, 260,000. We required that DHHS keep checking for eligibility with those people, that they kept, looking at them each month, but we couldn't take anybody off. But based on the redeterminations that they've been doing, 260,000 will no longer be eligible. So, but if we expand Medicaid, they will be. So we're already doing it. So we don't think it's going to be a lot of difference in the long run like it would have been before we started, because we've already added them since COVID started.
So you don't see a financial impact to the state, really?
No, I don't. And now Representative Lambeth, who is my co-chair on the AHME committee, he says that he will not approve any bill that costs the state any money. So somebody's got to pay that 10%. The hospitals right now, that has been the talk, that the hospitals would pick up that 10%. Hospitals have asked me to try to make sure that providers were part of that process, that the PHPs, they're going to benefit as well. So we're still looking at ways to do that. So that's all on the table.
Good. And just as background, so people know, Representative Donnie Lambeth is a former hospital administrator, so
right,
he's got some good background in this. Can you shift a little bit, not too far, and speak to how Medicaid manage Medicaid and that change to how we address Medicaid in the state, how it's working, because that's a relatively new endeavor. It's the Centenes of the world and folks that are now taking care of that aspect of our healthcare.
Transformation has gone remarkably well. We were expecting, we were actually training people because we expected our phones to ring off the hook with complaints when we went live with transformation. And it was not even a blip on the radar. We never heard any complaints in my office. I know there were some because, the PHPs have made us aware of a few things that they had to work on. But for the most part, it was not even a blip on the radar. It just went perfectly well. I think now people are well satisfied with what's going on. They'll be able to, and 97% were able to keep their primary care physician. So that was pretty remarkable, because that was one of the concerns that we had, that there would be a lot of confusion with people having to change providers, but it didn't happen. So we're excited about that. Oh, one other thing I did want to mention, Jeff, I forgot to mention earlier. Another thing that we're doing, we are working on transformation of the foster care system as we're transitioning to the Medicaid transformation. The managed care was just for the standard plans. The tailored plans were scheduled to go a year later. So as those tailored plans are being worked out, we're trying to separate the foster care children out of there, so that, because they're very transient. And right now the system is so fragmented that many foster parents are having to drive hours back to the previous county where those children were, because they can't get them transferred into the new LME. So we're transforming that, and we're going to have a statewide system where a child will have a card just like you and I do, and no matter where they go, they'll be covered. So we're anxious to see that happen.
Those kind of reforms are really important to see happen. So that's good news. Let's jump back to CON for a second. And in full disclosure, I've been an absolute supporter of both extremes, but nothing in between. And it sounds ironic. We either have to leave CON in place and leave it alone, or we have to completely remove it with maybe a caveat. But the stuff in between gets very problematic, as Mike Riley had pointed out, is to allow entities, particularly physician practices or an investor group, to come in and cherry pick the procedures because, I don't know, commercial pay and private pay is like 15% of a hospital's case mix and payer base. And that has to cover everything else that you're doing besides whatever reimbursements you get from the government. But if you allow them to take the profitable services, we'll bury hospitals financially. We'll basically shut their doors. They can't compete. But the flip side is CON is just a cottage industry for consultants and attorneys. So what can you share to the extent what you think CON would look like? What you guys are considering or thinking about, if it's not completely leaving it alone or just completely removing it?
I want to remove it. And the argument that you just made has been made in the 28 states that have already repealed it.
Are those repealed in total, Joyce?
All of them
No.
were not. I'm not sure how many were repealed in total. Okay. But Jeff, you and I know the federal government required CON in 1974, made it a federal requirement. States couldn't get funding if they didn't do it. Nothing that is ever put in place at the federal government, no matter how inefficient, ineffective, no matter how bad it is, it never goes away. CON is the only thing I'm aware of that the federal government acknowledged it was a failure, and they repealed it in 1980s. And many states repealed it at the same time, but some states did not. North Carolina was one. The only states that are ahead of us are Hawaii, Vermont, and New Jersey, I think. We have nothing in common with those states. We should not be up with those states as far as certificate of need. Now, we did make reforms in the last budget. We raised the thresholds. They had not been adjusted since in about 35 years. And so we raised those thresholds so that you could change equipment and that kind of thing without having to go through a certificate of need. We did a medical inflation adjustment, so it came up to today's money. I can't remember what the thresholds were, but I know we went from 2 million to 4 million on hospitals, I think. And we changed the time that they had to be done and that sort of thing. We did change where you can't sit on them, because right now people will get them and do nothing with them, or before we made that change. They could go apply for a certificate of need and never use it, just to keep anybody else from getting it. And so we changed that you have to use that certificate of need. It expires in 2 years if you haven't used it.
Gotcha. And do you have, and I'll put you on the spot a little bit, both on Medicaid expansion and CON, you have a general sense of time frame both might actually pass, or is it just we're too early to tell?
It's too early to tell. Originally, Representative Lambeth and I, his thought was that 6 meetings was not enough. And so we would just have these meetings and it would be a learning process, and we would be listening to what other states were saying. And we would, wait until long session to do it. But I think now he and I are both ready to come forward with something this year.
Sure. All right, I'm going to kind of shift back into the other topic that you all have mentioned, and that's the access to care issue. One of the concerns I see going on, both from being around physicians all the time, given my wife and daughter are both physicians, and firsthand experience, is the access. And I understand the issues. Like you said, we have 30 some counties with no OBGYN. Yet there's driving distance. And I know there's been a big push, Senator Heiss, for a long time about giving nurses independent freedom to open their own practices and clinics and just do their own thing, particularly in the midwifery area and those types of things around prenatal care and postnatal care. The question is, how do we control the quality of care? Because I see and Mike and all can jump in. Mike's a nurse by background. I'm not picking, but I see more PAs and nurses running urgent care centers and seeing more patients directly before an MD or a DO. And I could argue that we have lower quality of care. I know that'll be a controversial statement, but I see misdiagnoses because they don't have the training in the background. They don't have the depth to understand everything that a physician who's gone through potentially, 3 more years of residency, has gone through 1 to 4 years of fellowship. I mean, it's just not possible to have the same knowledge set. So how do we ensure quality care as well as just access to care?
Well, we already have that now. These nurses are practicing without a physician. I mean, they're supposed to have supervision, but I gave you the example. Right. They're really not supervising. Many of them are not. Now, some of them are working, collaboratively in a practice, and that's great, if that's what they want to do. But the data doesn't show that. Now, I think I'm going to say these nurses, they know the scope of their practice and they know they're not doctors. And when it's something that they can't handle, they're going to refer them to a physician. I feel confident of that. So I'm not worried about that aspect. But I think nothing will change basically, except they won't have to get that paper signed every 6 months.
And I get, and I sense most people would generally agree, having somebody sign a document once every 6 months, maybe reviewing a few charts, not really much supervision, not doing the patient any good at that point.
No, exactly.
So is there thoughts about changing the rules around quote supervision to be true supervision, or is the inclination more leaning to let people practice independently and then just expect them to refer to specialists, if you will, whether that be a general practitioner or whomever?
Well, the majority of the states have already done this, and their healthcare has not suffered. The data is pretty clear that there's no downside to that. So I'm not really worried about that. I think if we required that it be true supervision, they would say just go ahead and do full practice authority because then there's no benefit for it. So I think the support is overwhelming for the SAVE Act, overwhelming. I mean, the AARP, almost the only pushback is from some physician groups. They are the only ones opposed to it. Everybody else is fully on board. The data is perfectly clear. And I think that's going to happen.
So are there, these are obviously things you guys are in the middle of. So they're priorities in a sense, just because you're spending time on them. Other priorities for anything in the short session that's coming up that your committees will be dealing with or addressing?
Priority for me is the foster care system and the child welfare system. That's one of my top priorities. Because I don't know if any of you saw the report the USA Today did about North Carolina sending children to other states. Did you see that? It was an eight series report, and it was horrendous. And because we don't have beds for these kids, we don't have enough facilities. We can't use congregate care for more than 20 days, I think it is, or something like that. And so we're sending these children out of state. And I told our DSS secretary that I take a little bit of responsibility for that because I've been yelling ever since I've been there about children sitting in the ED for weeks and sometimes months on end. And that's just not acceptable. But so then we started sending these children out of state, and it's very expensive, and they're not getting care, and we have no control over the facilities that they're going to. And some of them were horrible. Look up those reports if you get an opportunity and read them. It will break your heart, absolutely break your heart. So that's a priority for me, trying to help our permanency for these children so they're not bounced around. Quick story. I had a foster family come visit me, and they had a girl in their home, and she was 14. She had been in 10 different homes in 22 months. That is not acceptable, not acceptable. And they loved her. They got a tutor for her. They got her involved in outside activities, youth groups, and that kind of thing. And she was thriving. DSS came in and said, we're taking her away. And the mom said, why are you taking her? We love her, and she's doing very well. And they said, the contract is up with Mecklenburg County. I went ballistic when I heard that story. And I called the secretary and I said, she came into my office, and I'm like, why would this ever happen? And the answer is, I'm not sure, Senator. I'll find out and I'll let you know. That's been at least 2 years. And I asked again last week, and nobody still lets me know. They do assure me that it's not happening anymore. A child should never be removed because a contract is up with another county. That's just the craziest thing I'd ever heard.
So moving on timeline wise, short session will be done short, I think, this time.
Yeah, that's what we hear.
Given you didn't really end the long session, it was just a continuous session.
That's right.
What
That's
people
right.
may not recognize between the short and the long session, you'll finish sometime this summer and it'll be next January before you reconvene for the long session. There are joint oversight committees that go on every month, different studies, topics. Is there anything been identified for that oversight committees to be addressing or looking into while you guys are out of session but still working?
No, the oversight committees are going on now, of course, as you know. The Medicaid expansion is one of our oversight committees,
Okay.
HHS. They're all going on right now. Those are the standard ones. There may be some more specific appointed committees that like this one is,
Sure.
but we're not aware of them at this time. I guess it will depend on what needs to be addressed, and then we'll go from there. But I'm sure there will be some new ones, most likely.
Sure. Well, the plate's pretty full with huge topics. Anything that you see added or maybe being added in the next long session?
I'm not certain. Budget, of course, will be coming up again, even though we just got this one passed. And we'll be doing some budget adjustments when we go in the short session, and then long session next year. We won't have nearly the money next time because we had all those COVID funds this time.
Right.
I have some concerns about that because, we did a lot of one-time funding to help everyone get through the pandemic. And we're already hearing, we did some pay raises for some of the direct care workers. We did bonuses. And they're not going to be available next time. And yet we're already hearing, we can't cut that payback. So y'all are going to have to do something. So I'm not sure how we're going to be able to deal with all of that, because we know there is a huge problem with the direct care workforce and the wages that they're getting. They're just not sufficient to retain good quality, talented help. And now with work shortages everywhere, they're going on to other things that aren't nearly as stressful, aren't nearly as demanding as being, a direct care worker. So all of those things are big concerns.
So around the budget, I know one suggestion by some folks has been to take funds out of what's referred to as the rainy day fund, which are for emergencies and so forth. And since it's a fairly significant amount of money, to shift it into general funds and allowing you, like your committees in particular, to and the education committees to appropriate those monies. What's your thoughts?
We get a lot of pressure for that. That money is for emergencies. And we're just not going to do that. We've worked really hard to build it up, to get it where it is now. And it's, it's substantial. And there will be pressure to take the money out of it. But we will have another downturn. We will have a recession. Many economists are predicting it'll happen next year. And if that happens, then we'll use those emergency funds. But we won't use it just to appropriate and just to put into the general fund just to spend. That's not what it's about. And that's not what it's for. But we will use it for emergencies.
Great. Good to know. Two areas to kind of maybe speak to briefly, and whether there's any conversations. So the answer may be a quick no, but conversations around pharmacy costs and price transparency tends to be topics talked about, at least in people's around their kitchen tables. And also you hear it on a national basis. Any thoughts, discussions, any work being done in those areas at all?
There is work being done in those areas. I had a bill, you talked about the price transparency. I had a bill on surprise billing last time. I'm still going to work on that. Patients should not be getting these surprise bills. And my bill that we had last time was just simply, and I mean, we've been trying to do this for a long time, as you know, and never get anywhere. So last session, I had this, I thought was a brilliant idea. Okay, we won't change anything. We'll just say the hospital has to let the patient know. You just have to give them notify them that someone working there may not be in network and that they may get an additional bill. Just let them know. And well, my brilliant idea didn't go very far. So, but I'm still going to work on it because that is just wrong, just wrong.
Yeah. Healthcare is a tough industry. Again, being around it and working in it for 40 years. I mean, it's one of the few things in life where you go to acquire the service or product if you're getting a knee replacement or whatever else, and you cannot get an exact price of what you're going to have to pay to make a decision whether you want to go forward. Now, sometimes when you're in an ER, you've been in an automobile accident, you're really not worrying about what the price is at the moment.
Right, that's right.
But you still, it's a unique thing that you get billed after the fact. You don't even get told what the cost is until after the fact.
Yeah, we would never use another service without knowing what the cost was. We wouldn't even consider buying a car or buying anything without knowing what it was going to cost. But we don't pay for it. That's why nobody really pays attention. In the long run, we do, but
related area, and you mentioned it a little bit with the MRIs and the issues we'd have with CONs, and we have it. We can get into it. I'm not an advocate for universal health care, but is there discussion around pricing of services, the cost of services? Because you can, we can get in a whole long discussion explaining why, but you can go to one hospital and the price of an MRI is X. You go to another hospital that's $1,500 less, another one it's $2,000 more, and you do that across the whole entire charge description master of all the services that a hospital can perform. And there's reasons why that exists, but there's also states like Maryland, which is a case rate state where the state with a particular body sets the prices and everybody charges the same thing. Has there been discussions or are there issues around that get discussed?
No, we believe in free markets, and I don't think we'll ever get into setting a price for a service for healthcare. The market will set those prices if the market is a true free market. Right now, it's not. And of course, it's not a free market because the government pays for most of it and they pay below the rate. So, but we won't get into any rate setting. But I think at some point, maybe others might, but we certainly
Sure.
don't have any conversation about doing that.
Couple last quick questions in the healthcare, and then I'm going to shift to our favorite topic, which is redistricting and map drawing, which I love to do. I love to get the crayon box out. But anyway, last two things, and then if there are any other things that somebody, I've had a few chat comments and covered most of those, I think. But the health information exchange, which has had varying levels of success and usefulness. Are you familiar with what's going on in anything going on with the HIE in North Carolina?
Nothing now. We did extend it because we had the pharmacies, the CVSs of the world. Everybody said it wasn't compatible with their systems. And so we did extend it. But I think, Senator Hayes is determined that that's going to happen. And he didn't even want to give them an extension, but we really had to. Some providers that are small, it was very expensive. They had, there had been conversations that there would be a product coming out that would be very affordable. Well, it didn't happen. And some just couldn't afford to pay to be on the HIE. It was just going to be too expensive for them. So, but that's still in the process of moving forward.
So I believe and it wasn't that long ago we require hospitals and physicians, care providers, to supply all the clinical information, medical records information on their patients to GDAC, which is the Government Data Analytics Center housed at SAS. That will still progress and continue?
Yes. Yes,
And
that will still, hopefully it will be completely statewide and live. Since you're talking about, one thing we did do, this was absolutely unbelievable to me. Our state hospitals still had paper files. They were not computerized at all.
some of the small facilities.
Yeah, Senator Bergen went to visit his state hospital out in his district, and they were going from room to room carrying just, folders, just loads of folders.
And record charts.
So we allocated funds so that they could data could be electronic and they would not have to carry around those files anymore.
It's amazing because obviously it changes, and Mike could speak to this, but my wife practicing at another system not to be named, they have basically said if you're not up and running and competent on Epic, you will not be allowed to practice. So they're not going to be manual in any way, shape, or form. So we see more of that. So
well,
I'm
those state hospitals will be Epic. If they're not already, they will be, because we did allocate funds for that to happen.
Interesting. That's good to know. Well, just to shift because we only got a few minutes left anyway. Can you share your thoughts on what's going on around the redistricting, just your interactions in the committee, how that process unfolds, all the great and radical gerrymandering that you guys obviously do?
Well, I'll use my district for an example. We are supposed to be redistricted every 10 years. You keep your district for 10 years. This will be my 5th election and my 5th different district. I have never had the same district twice. I had Yadkin County, I had Davie County. Now I have Stokes County with different parts of Forsyth every single election. So that shouldn't happen, first of all. Our Constitution is clear. The legislature draws the districts. And for 140 years, Democrats drew the district because they were the majority. And we know what the Constitution says. So those districts held for 10 years. Well, the first time that we draw them, then we're sued. And they have been redrawn and redrawn and redrawn every 2 years. And it's crazy. It's ludicrous. This time we had a fully open, transparent process. We had meetings all around the state. I chaired one there in Vicky's district. It was in Iredale in Statesville. I chaired one there, and I chaired one here at Wake Forest. And where public had complete input, we heard from all the citizens, we heard from organizations, and other members were doing that in other parts of the state. So we heard from everybody. We went through a very good process. We did not use any data. We used no racial data, no political data. We just let the counties, we left counties whole, we left municipalities whole. They were great districts. We were sued, and of course the Supreme Court in North Carolina basically had a map drawer redraw the districts. And so we probably will redraw them again. I know we'll redraw the congressional again. I'm not sure about ours because we did end up redrawing them ourselves, but at the direction of the map drawer, doing what the map drawer told us to do. And so it was a much fairer process the way that we did it. And we will probably do it again. So I'll probably have this district for 2 years and then it will change. So.
I try to stay away on these things from taking political positions and ideology, but it sure raises the 64-cent question. I mean, courts, particularly at the Supreme Court level, state or federal, their sole purpose is to judge whether a law is constitutional or unconstitutional.
Right.
It's intriguing that the Constitution of North Carolina and most states say the legislatures draw the map, and then the Supreme Court hires a map drawer, which is in violation of the Constitution. So they put it, they do an exercise that's unconstitutional to solve something they deemed that wasn't in their view the proper outcome, but they never ruled whether it was constitutional or unconstitutional. So they're not even following their own laws. It's just,
that's right.
It's a
Same
bizarre process.
Voter ID. The people voted to change the Constitution.
Right.
How is a vote by the people unconstitutional to change their own constitution? How is that unconstitutional? So, you know, we tried to move the that to the redistricting issues to the US Supreme Court, but they ruled that election law is strictly a state responsibility.
All right, last question, the big one for all of us out here. So what do you do for fun besides live at the legislative building all the time?
I like to read other stuff other than bills when I have an opportunity. I do like to do that. And I enjoy gardening. So hopefully I'll get to do some of that now that the weather's warmer.
We're getting there. Well, Senator, it is an honor and a privilege to spend time with you. You are insightful, you're thoughtful, you're unbelievably ethical and moral, as I know you personally, and you are truly a good friend to not just me, but I mean to the entire state of North Carolina, because I know you represent us all with your best interests and our best interests at heart. So thank you for taking time out of your busy schedule.
Thank you, Jeff. And I still miss you. Come see us.
Any last thing you want to share before we give the podium back to Bill?
No, I think we covered pretty much everything. I do want to apologize to Mike for disagreeing with him on certificate of need, but he knew that before we started.
I understand.
So
all right,
it's great to be with all of you. Thank you so much for having me.
Thank you, Senator. Bill, the floor is yours.
And I'd like to again recognize Mike Riley, the president of Huntersville Medical Center and Novant Health. Mike, any last thing that you would like to share in regards to the program today?
Senator, thank you so much. Fantastic job. And Jeff, just so you know, I know it's not the nurse practitioner, so the SAVE Act is a little different, but my wife is a PA and she's downstairs right now seeing psychiatric patients who we don't have enough doctors to see. So that's a little microcosm. Imagine what it's like in some of the rural areas to see patients. So, but I hear what you're saying. I don't want you to ever say that in front of my wife, though. You'll offend her. So I just wanted to give you that heads up.
Okay.
But again, Senator, thank you so much. Fantastic program. Really appreciate all the information you brought.
Thank you very much. Great to see all of you. Thank you.
Thank you, Mike, and thank you, Senator. Jeff, thank you very much for emceeing today. Jeff Tarte is our public policy chair. We've just approved our legislative agenda. We have also prioritized our legislative agenda. Maybe we can carve out some time for next month's Focus Friday and you can talk about the 3 areas in each sector that we're prioritizing and the 3 overall. So we're going to carve out some time. You want to speak about next month's program?
Sure. We have State Senator Mike Lee with us next month, and Senator Lee is the chair of the Education Committee in the Senate. And so we'll be talking all things education, except for the balance of our legislative agenda.
Well, I want to thank everybody for joining us today for the Focus Friday, and I hope everybody has a fantastic Easter weekend and a wonderful wonderful Good Friday. Thank you.
Thanks, everybody. Great to
guys.
see you.
Adios.